Hello, everyone, and thank you for joining us in Community Chats. Today, we are celebrating Colorectal Cancer Awareness Month. And of course, we have with us one of the best, if not the best, I just say one of the best, just to be polite to others. But to me, Dr. Taylor knows, to me, he's the best and always will be. So Dr. Taylor is one of our doctors here, is gastrointestinal doctor. And he definitely has a lot of specialties. He graduated medical school at the Albert Einstein College of Medicine of Yeshiva University after he had already earned a master's degree in biology from Tulane University. Then after medical school, Dr. Taylor completed his residency in internal medicine and then his fellowship specialty training in gastroenterology and hepatology at the Robert Wood Johnson University Hospital at Rogers Medical School in New Jersey. He worked for several years at the biotechnology company developing new medications, one of which is on the market now for Crohn's disease. He's also the author of numerous scientific articles in the field of gastroenterology, and he's a board-certified fellow in gastroenterology and liver disease. So it's like we're having a true celebrity in Community Chats today. I'm so excited. Thank you so much, Dr. Taylor, for being here. It's so great to have you.
No problem. So yeah, so Sandra asked me to talk about colon cancer screening, which is, obviously one of the major things that we do as gastroenterologists. And obviously there's a lot of benefits to doing colon cancer screening. The main one, of course, is that it saves lives. And the statistics are undisputable. It does save a lot of lives. It is one of those screening tests that actually works very well. And is highly effective. Unfortunately, maybe about half of people who are eligible for getting colon cancer screening actually get colon cancer screening of any type. So it is something where there's a lot of space, room to grow, as a strategy, just because not everyone goes for it. Now, of course, it's not required to get colon cancer screening. It's just a strong medical recommendation. And with that being said, I'm assuming you guys can all see the slide that I have up here. This is the intro slide. You can see it, Sandra, so I can start right now.
Yes, you can. Go ahead.
Okay, very good. All right, so colon cancer screening. So first off, what is colon cancer and what are polyps? Because when we talk about colon cancer screening, we're actually talking about preventing cancer by removing polyps, which are the precursors, the things that will become cancer if left in. All right. Polyps are slow growing. They could take many years to become cancer. And so there's this opportunity to go in and remove them. Now, who gets polyps? I'm going to talk about that. I'm going to talk about polyp screening, which is really what we call colon cancer screening, but really we're looking for polyps. And we're going to talk about the colonoscopy procedure, since that is the gold standard for preventing colon cancer. So what is colon cancer itself? So this is out of control cell growth, where some of the cells in the lining of the colon start growing and they become a mass. They become a large lesion there, and this can cause a lot of different problems. Now remember that the cells in the lining of the colon and the intestinal tract are constantly growing and moving up, just like your skin. Your skin grows and the outer layers of your skin slough off and fall off, and the under layers kind of come up and replace them. The same thing is happening in the cells in your gut. And if some of those cells fail to slough off and fall off, then they can turn into these polyps. So over time, when they become cancer, this can cause a blockage of your colon. So you get an obstruction that can end up causing you to vomit or something like that. They can also bleed. They can bleed slowly and over time cause anemia. So you could become symptomatic from being anemic, which means, for instance, you might be very weak, you might be tired, you might be short of breath because you don't have a good blood supply in the body anymore from all the bleeding. The polyps, or not polyps, the cancer can also perforate or cause a hole in the colon, in which case bacteria in your colon can get into your abdominal cavity. That would cause sepsis. That's a very sudden thing. where you get a lot of pain and all of a sudden high fevers and all kinds of stuff like that. That's usually pretty advanced though. And also colon cancer can spread to other organs around the body, and most typically it spreads to the liver, where it is possible to be diagnosed with colon cancer because you turn jaundiced because your liver is not functioning properly. So these would be things that can happen after you've developed colon cancer. Now here on the left, we have a normal looking colon on a colonoscopy. And then on the right side, you can see a big tumor here, a growth, and that would be, an invasive colon cancer. But that's what that looks like if you were to come across a colon cancer on a colonoscopy. And I'm sorry, but some of the pictures here are, pictures from inside the body. So I do apologize if anyone there is squeamish, okay? Now, how do you detect something like this on radiology? Well, in the old days, you used to use barium radiology, and you could see something called an apple core lesion. So on the left here, I just have an example of that. That's where somebody got a barium enema, for instance, and it shows what looks like an apple core, but that's really the tumor growing, in such a way that forms it like that. You can see that on a CAT scan also, if you do that. And then the lesion on the right just shows a whole bunch of liver growths, the spread of the cancer to the liver. So liver lesions, something like this could indicate that you have metastatic colon cancer as well. So symptoms that could clue you into this, we already mentioned. If you have any of these symptoms, then you should definitely be seeing a doctor. If you're seeing blood in your stool, if you have weakness, tiredness from anemia, if you have abdominal pain in your abdomen, or you have something that's an unusual change in bowel habits, where all of a sudden now you're having severe constipation, you never had that before, and having trouble going to the bathroom, these would be alarm symptoms that something is going on there. But in truth, most of the time, if you have colon cancer, you're probably not going to know it until it's very, very advanced. So, but if you have any of these alarm symptoms, you should definitely be seeing your doctor or a GI doctor, okay? Now, we mentioned before that almost all colon cancer come from polyps. This is an example of a colon polyp here, not the little white thing. That's just the light from the scope reflecting off the mucosa, but the thing on below it is the growth. And that would be maybe a 4 millimeter colon polyp seen probably in the rectum or sigmoid colon looking at this. And this is what we're looking for when we want to prevent cancer. We want to cut it off ahead of time before these polyps grow bigger and become cancer. So here I have a polyp progression illustration. And you can see that on the left side are polyps that haven't become cancer yet, although you can see on the rightmost of the left side of polyps, there's a white area that actually signifies cancer. So you could actually get a little bit of cancer on the tip of the polyp that hasn't spread yet, and you can remove that polyp, and that's curative right there and then. It hasn't spread anywhere in the body. But as you can see, as it progresses more to the right, the polyp becomes much larger, and now the colon cancer on the tip of the polyp now is invading into the regular part of the colon. And then the one way on the right just shows invasive cancer, where it's now invading into the rest of the body. So you want to remove these things ahead of time before they become a problem. All right. As I mentioned before, to form a polyp requires a mutation or a change in the DNA, where the tissue fails to slough off and fall off, and it becomes adherent and sticks to the lining of the colon. And that's what becomes the polyp. And it takes years. It could take 5, 10, maybe even 15 years for that little piece of tissue that's adherent there to grow bigger, 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 and then transform into cancer. So there's a nice window of opportunity here. Most of these mutations are random or sporadic. And they just occur in a single colon cell. They're not necessarily inherited. They're due to bad luck. Only less than 10% of colon cancers are linked to some kind of a genetic syndrome in the family. 90% are not, okay? And I do tell patients that sometimes you could be an absolute angel in terms of your diet. You could be a vegan. You could be a marathon runner in tip-top shape, but you still are at risk of getting polyps. Okay, now maybe the risk is slightly less, but still anyone can get polyps, even if you're live a very saintly lifestyle. Okay. There's about 150,000 cases of colon cancer every year in the United States. So this is a pretty common issue, colon cancer. And there's about 50,000 deaths a year from colon cancer. All right, that makes it the second leading cause of cancer death after lung cancer. And one of the top causes of death, although heart disease and stroke do remain the main causes of death. Just so you know, automobile accidents, just to give you an example here, automobile accidents are about 39, 40,000 deaths a year. So there are actually more deaths from colon cancer than automobile accidents every year. Okay. Your lifetime risk of getting colon cancer statistically is about 6%. About 6 out of 100 people get colon cancer during their lives, which means if you don't do any screening, you still have a 94% chance you're not going to get it, but still 6% is high. If you went over to the Palisades Mall or, a crowded place, you're going to see 100 people without too long a period of time. And then remember, 6% is 6 out of 100. So it is out there. Even though it may never happen to you, it does happen to somebody, and you don't know if you're one of those 6 out of 100 or not. Remember, that's lifetime risk. That means into your 90s. So it doesn't mean you're necessarily going to get it at age 40 or age 45, but it does occur at earlier ages, although the average age of diagnosis is age 67. So it's not that average age of diagnosis is 40 or something, okay? Now, population can differ in the risk of colon cancer. In fact, if you look at this graph here, and I don't want to dwell on it too much, but the dotted line or the dashed line that's orange is African American population, and then the blue line is a Caucasian population. You can see that there is an upturn in the incidence of colon cancer around age 50 or so, but this uptick occurs a little earlier. There's an earlier shift in the African American population. Therefore, African Americans, we found, were getting colon cancer at an earlier age, and this is one of the reasons that we moved the screening age from 50 down to 45 a couple of years ago. So now we recommend that everyone get a colonoscopy or a screening test starting at age 45, just because this data was out there showing an earlier shift. All right. I'm not going to dwell on it more than that right now. Okay. All right. Other risk factors that could be out there. Males slightly increased risk over females for colon cancer, but only a very minute amount. As I mentioned before, African Americans do have a higher risk. If you have a low fiber diet and you don't eat a lot of fruits and vegetables and you eat a lot of processed foods, your risk will go up slightly again. And the big one, of course, is smoking. 25% more risk of getting colon cancer if you're a smoker. Also, excessive alcohol use will increase your risk, as well as obesity, diabetes, and believe it or not, if you've had your gallbladder out, it also increases your risk of colon cancer, but of course, only a very small amount. Okay. Things that lower risk, believe it or not, aspirin use does lower risk of colon cancer. And in people who are very high risk because of family history or have a genetic condition like familial adenoma polyposis syndrome, we do recommend that they take aspirin for this. However, aspirin does have a lot of risks to taking the aspirin, like kidney problems, stomach ulcers, and stuff like that. So we don't recommend that people in the general population just take aspirin for the heck of it. But it has been shown that it will lower your risk of getting colon cancer. Okay. Other things that could help are B vitamins, supplemental fiber, because it helps to slough off the outer cells in the colon. Being on calcium, vitamin D, which is especially important here because here in the Northeast, people tend to be deficient in vitamin D, but it does help your immune system and it does lower risk of colon cancer, but only a little bit again. Fish oil, which kind of works in the same way that aspirin does. It's an anti-inflammatory process. And believe it or not, garlic will lower your chance of colon cancer. Again, only a small amount, but it does theoretically, and according to the research, lower your risk, but only just a teeny bit. Okay. So if you have garlic breath, you can tell your partner that you're doing your part to lower chances of colon cancer. All right. But the main reason you're going to prevent colon cancer, the main thing you can do would be colon cancer screening, and basically for polyps and removing them. Okay, that would be the main way to prevent this condition. Now, at age 50, we find that about 20 to 25% of people will have a polyp in there. And since we've lowered this down to age 45, it's been shown that about 15% of people will have a polyp. So even if you go for a screening colonoscopy, it doesn't mean we're going to find a polyp. It means you got a 20 to 25% chance of having one if you're age 50, and about a 15% chance of having a precancerous polyp if you're at the beginning age of screening at age 45. Now, there are different types of polyps out there. I'm just going to mention briefly. There's hyperplastic polyps, which are the one on the top right corner of this slide, and those are not precancerous. They do not transform into colon cancer, but sometimes we see them, and a lot of times I'll remove them because I'm not 100% sure if it's a hyperplastic polyp or not. I'll take it out, of course. But the other types of polyps, the main one is the one on the bottom here, tubular adenoma on the bottom right. Those are the main and most common ones. And then there's another one that's a little sneaky. It's called a serrated adenoma, which are kind of flatter and harder to see. And those are on the bottom left. Okay, and these are all precancerous polyps. So how do we detect whether you have them? Well, as I mentioned before, colonoscopy is the gold standard. But first, I'm just going to talk about other methods. Then we'll talk about colonoscopy. One of them is the fecal occult immunohistochemical test for looking for minute amount of blood in the stool. And this is actually recommended annually, rather you're particularly looking for a colon polyp or not. It is a good idea. This involves just a tiny, minute amount of stool in this reagent. A lot of times doctors will do this in the office. There's also cards that can be sent to the house where you put a little bit of stool on the card and you send it back in and they test it. These are cheap. The bottle ones with the little wand here, the green wand, they cost about $17. The card ones cost even less. And they could pick up a big polyp that's in there or anything that might be bleeding in the intestinal tract. However, they're not perfect. They only have about a 20% chance of picking up a polyp. So they could easily miss a polyp as well, especially small ones. But it is a screening method that's out there. All right, here's the card form of it, where you just put a little bit of stool on the card and then mail that back in. The card turns blue when you put the reagent on it if there's blood in the stool, and that would indicate you should get a colonoscopy. Now, we've all seen the commercials on TV for the Cologuard box kit. Okay, now remember the fecal occult blood stool test that I just mentioned cost $17. Well, the Cologuard costs $500 or more to do, but it's actually not all that much different, believe it or not. Okay, if you read the label on the box kit, it does say that any results should be interpreted with caution because a negative test does not confirm that you don't have cancer. And of course, they're not even talking about polyps here. They're talking about cancer. And also, you can get positive tests from having any kind of blood in the stool as well, which means hemorrhoids that are bleeding or a stomach ulcer that's bleeding or gastritis could make the test positive. So if you do go for one of these tests and it comes back positive, just don't freak out. You may just be a positive test because you had a little minute amount of blood from something else going on in the intestinal tract, okay? Now, if you look at the New England Journal of Medicine article on the Cologuard test, these are the results here. If you look at the top arrow, yellow arrow there, it says 92% sensitivity. That is what the sensitivity is for the box kit for finding a tumor or polyp bigger than 2 centimeters. So this is a very effective test for finding something bigger than 2 centimeters, which is about an inch. Okay, no question about that. However, if you're looking for polyps that are a little smaller, between 1 and 2 inches, then you go down to the second yellow line here, where you get a 42% sensitivity. So it's even less than 50-50 chance you're going to find what they call an advanced precancerous lesion or a polyp that's between 1 and 2 centimeters. Okay. And if you're looking for a polyp that's 1 centimeter or less, they call that a non-advanced adenoma. It is 17.2% sensitive at finding that. So just be aware if you do the Cologuard test, it is only good for larger lesions. It can pick up the smaller polyps too, but not necessarily reliably. And this is one of the reasons that they recommend they do this test once every 3 years if you go this route for screening. Okay. That means, getting back to this, if you have a tumor there, 92% chance of detecting it with Cologuard. If you have a 1.5 centimeter polyp like this, you have a 42% chance of detecting it with Cologuard. And if you have a tiny little polyp like this, you have a 17% chance of detecting it with Cologuard. So just be aware of that. Now, I already mentioned it's only good for large lesions or polyps, not necessarily for small ones. All right. Next modality we're going to talk about for colon cancer screening is not used very much, but this is CT colonography. So what this is a CAT scan that's looking to see if they can find anything growing on the wall of the colon. Now, you still have to do a prep to clean yourself out. And when they do the CT scan, they put a tube up your butt still, and they inflate air to distend the colon. So it's not necessarily a scot-free test here. You still have to drink all that stuff that cleans you out, and you still have something put up your butt. And there's no anesthesia used either. But the idea behind this is that if there's any lesion that makes a three-dimensional kind of fly-through of the colon, any lesion like a polyp or a growth or anything might get picked up on this three-dimensional reconstruction of what the colon looks like from the inside. Okay. And here you see a regular CAT scan on the right, and then the three-dimensional reconstruction of CT colonography on the left. Okay. Now this won't pick up flat lesions all that well, but it will pick up protruding lesions in the colon. And of course, you have to make sure that the prep was really good, because little pieces of stool could complicate things. And also, you have to make sure the colon is distended with air. Otherwise, you don't get a good visualization. It's really a good test for, let's say you had bad lung disease and you're not a candidate for anesthesia, something like that. It might be a good test for something like that. The benefit is that there's no physical scope inserted. But as I said, there is still a rectal tube. There's no sedation. Disadvantages, you have to clean out. It's only 94% chance of finding a polyp greater than a centimeter. There's some radiation exposure, but that's not such a big deal. You can't remove the polyp if you find it, so that means now you have to do a colonoscopy afterwards. And there are reported cases of perforation where you inserted the air in the colon and it caused the colon to pop or perforate. So that still is a risk of doing the procedure. There's also a video pill that you can swallow. This is used a little more in Europe than here. It's not a very effective test as well, but it is an alternative to colonoscopy, and it's not really offered very much. But here you can see that the video pill took an image of what looks to be a polyp here, a 10 millimeter polyp in the colon. This means you have to distend the colon with a lot of fluid, meaning you have to take a huge prep to clean yourself out so you can see visually. And then you have to drink a tremendous amount of fluid with the video pill to distend the colon so you can actually see what's going on as the pill cascades through the colon. Okay. But it is less invasive, and there's no sedation, and there's no need to stick anything up the back way for this. I was at a conference where they were talking about using this in Europe because the waiting list for getting a colonoscopy in Europe was 6 to 10 months. So they were using this for people who looked high risk to make sure that they didn't have something bad going on so that they could wait those 6 to 10 months to get their colonoscopy. And that brings us to colonoscopies, which, as I said before, is the gold standard here. So this is unfortunately a tube that we do stick up the colon and wind our way around about 3 feet in. There's a few channels in the scope, so we can put some tools through that. We can flush water through it. We can suck things through it. And of course, we can spend time looking for polyps as we're doing this, okay? It does involve sedation. You would be basically on your side for the procedure and snoring. We have an anesthesiologist that gives you usually propofol for this so that you're perfectly comfortable. It's fast acting, and you wake up within 5 minutes or so of us finishing the procedure. But you do have to have a ride home afterwards and some stuff like that. Now, here are some findings that you might see on a normal colonoscopy. The top left picture is what a normal colon looks like with the normal lining and normal blood supply. The top right shows a few little pockets or pouches in the colon, and these are called diverticuli, and they're fairly common. About 20% of people have them. They occur where there's a weakness in the muscle wall where the little blood vessels feed in, and they can outpouch and become these diverticuli over time. If they ever get infected, that's called diverticulitis, which you may have heard of. And that's an infection where where the bacteria has gotten stuck and growing out of control in one of these little pockets. Usually treated with antibiotics, occasionally would require surgery. Okay, just so you know, there will be things on the internet saying to avoid seeds and nuts if you have these little pockets, but that's actually never been shown or proven to be true, just so you're aware. Down on the bottom left side is the ileocecal valve, which looks a little bit yellow and a little thickened. That's where the small bowel attaches to the colon. And right behind the ileocecal valve, you would have the appendix, which you have down on the bottom right. That is what the appendix looks like from the inside when you do a colonoscopy, and that looks perfectly normal. Here we have a picture of a polyp on the right side, and I have a little snare there, which I'm going to put around the polyp to remove it. And then the cartoon image on the left just shows one method of removing a polyp, which is to put a snare around it and snare it off. This could either be a cold snare or a hot snare. If it's a larger polyp, I will use a hot snare to burn it off at the base. But if it's small like this, you could just do it with a cold snare to remove it and then hopefully be able to suck it through the channel of the scope. Otherwise, you'd have to retrieve it and bring it back and then put the scope back in. Okay. Clean out is very important when it comes to a colonoscopy. Here we have on the left, again, a normal colon, which is well cleaned out. But on the right side, you can see a colon prep that didn't turn out so great. And there's a lot of liquid in there. It's going to be possible to miss things. So little polyps could get missed if the clean out is not perfect. Now, you could follow the instructions for the clean out and still end up with a suboptimal prep. But it just shows, though, the importance, definitely follow the instructions, no cheating. So I have had people in the past say, well, I was hungry, I had a sandwich at 8 o'clock at night the night before. It's only going to harm the clean out and may make it so that we miss things. So if any of you guys do get a colonoscopy, please read through carefully ahead of time and follow the instructions. Okay? All right. Generally, the clean out will involve being on clear liquids for most of the day, or if not the entire day before the procedure. Most of the preps I have, you start at 8 a.m. the day before the colonoscopy, and you're still only taking clear liquids, which include things like apple juice, Snapple iced tea, ginger ale, Gatorade, stuff like that. Okay, it doesn't prevent you from going to work. You're just on a liquid diet. So you can still go to work, whatever it is you're normally doing, no problem. I'm assuming you're home by 6 o'clock or so, because that's when you take the rest of the prep, which gives you the diarrhea and flushes everything out. Now, there's a few different options with that. One of the main options that people use is a Miralax prep, which is a powder. It comes in a bottle like this. This shows a 4.1 ounce bottle, but it's actually 8.2 ounces that we use for the prep, just so you're aware. And you have to mix it into 96 ounces of Gatorade. And here we have the example of Gatorade. This was the type with no sugar. So if you have diabetes and you don't want the extra sugar, you could use the Gatorade Zero if you wish. But this is one of the clean out methods. You have to mix it together, maybe put it in a big pot to do so. And then you have 3 to 4 hours to drink it all. And of course, that's going to result in volcanic eruption and diarrhea from below. Okay, that can be a little tough to take. 96 ounces is a lot. And sometimes people are not so thrilled with it. Plus, also, I find that some of the prescription preps that are out there may do a little bit of a better job than this even. But of course, those are prescription preps. They're not necessarily for everybody. And sometimes they're subject to the insurance covering the prescription. This is one of those prescription preps. This is Suprep, which are 2 liquid vials, which you take along with 6 of those cups that are on the right there with the red line over that. You have to do a total of 6 cups with those 2 liquid vials over the course of a number of hours. It is less volume than the Miralax prep, and I think it does a better job, but it does cause some shifts in potassium and sodium and phosphate in the body. So if you have significant, serious kidney disease, for instance, you shouldn't be on this. If you have significant heart disease, you shouldn't be on this. But it does do a better job, in my opinion. It's just a prescription, and subject to coverage. It also comes in a terrible cherry flavor, which could maybe blunt your desire to have cherry flavored stuff afterwards. Who knows? It does come in a tablet form as well, and this is actually what I tend to prescribe the most of. They're called Sutabs tablets. Unfortunately, it's 24 total tablets, 12 in each bottle, but it's done similar to the other liquid prep, the Suprep, where you have to do a whole bunch of pills with 3 cups of water. Then you wait a while and you do the other set of pills with another 3 cups of water. I think this is the easiest one of all of them to take, and it does the best job. But again, you have to be a pill person. They're reasonably sized pills, and some people just don't like taking pills either. Okay. If this is not covered with the insurance, there is a coupon where you could pay $60 for it. But again, $60, that's a judgment call on people. Some people, that's a lot of money, and others, they're saying, well, if I'm only doing this once every blue moon, maybe it's worth it. Okay. The procedure. Now, just so you know, I don't know if I talked about the interval. I'll talk about the intervals of when we do this a little later. The procedure itself takes about 15, 20 minutes to do. We make you sleepy for it. Either it's in an office or a surgery center or over at the hospital for it. After the procedure, you may take 15, 20 minutes or so, 10, 15 minutes to sort of get up and get dressed and everything. And then you're able to walk right out. You just cannot drive right afterwards. You have to either have a chaperone and a taxi or somebody else drive you, but you cannot drive your car for a number of hours afterwards. Okay. Typically, the anesthesiologist will say till the next morning. I don't know exactly what the data is, if there's a 8-hour, 10-hour time limit or whatever, but regardless, you're not able to drive for a number of hours afterwards. You're going to feel fine, though. It's just more of a legality purpose, because if you drive and you had a car accident, they could say your reflexes were slow or your judgment was off or something like that. So they want to make sure that the medication's completely out of your system. After the procedure, as I said, you wake up very quickly. Any polyps that were taken out, you can call up a week or two later. We'll have the results. If there's no polyps, we generally say 10 years, and that's if there's no polyps and no family history, I should add. If you do have a couple of small polyps, we usually tell you to come back in 5 years. Okay? And you can have whatever you want, filet mignon, lobster, whatever you like, as soon as we're done. If you're looking to be screened, you can contact a GI doctor of your choice, or you're welcome to call us as well, or talk to us through your primary provider. This is our contact info if should you need it. We're now part of Highland Medical, but I'm Dr. Tater. I also work with Dr. Silver and Dr. Korenfeld. I'm happy to answer questions at this point, so I'm going to stop the screen sharing and go right to the question mode. Okay, are you there, Sandra?
I am. Thank you so much for this presentation. Very comprehensive. And as a matter of fact, I was looking here and there were people that said, yes, oh my God, you answered all my questions already. So that's great. Thank you for that. Here are a few questions from the audience. Are the Cologuard tests enough to test for colon cancer, or would you still recommend to follow with a colonoscopy?
So as I mentioned before, the Cologuard is technically a screening test for colon cancer. Now, if you notice, they say colon cancer. They don't say it's a screening test for colon polyps. Okay. And if you watch the commercials on TV, you'll notice that they say, yeah, colon cancer screening. Well, yes, you are looking for cancer in that test, but you're not necessarily looking for small polyps that might become cancer in 5 years from now. You're looking for large polyps or cancer that's already there. So it's a little misleading is what I was trying to say before. Now, that being said, if you had a negative Cologuard, the chance of having something big or bad going on is probably very small. But it doesn't exclude a 1 centimeter polyp that might become cancer in 3 to 7 years from now. Okay, and that's why they only give you 3 years with the Cologuard test. It's only good for 3 years. Somebody did ask before about screening before age 45. I'm going to talk about that in 1 second. But the Cologuard test is not for somebody with anemia. It is not somebody who's seeing blood in the stool. It's not FDA approved for that, just so you're aware. And if you have a family history and you're high risk for colon cancer, it's also not approved for that either. If you look at the package insert, it's only for average regular risk people in the population to do every 3 years. And as I said before, it's only going to pick up bigger things that are in the colon, but perhaps before they become a problem. Okay. Now, in terms of screening before age 45. So 45 is the recommendation for an average risk person. If you have a family history, we may want you to start earlier. So a family history is somebody who has either one first-degree relative with colon cancer or two second-degree relatives. A second-degree relative is a cousin, an aunt, a grandparent. A first-degree relative would be a parent or a sibling or a child even. Those would be a first-degree relative. So those people you would either start at age 40 or at an interval that's 10 years before that cancer was diagnosed. So if you had a sibling who was aged 45 and was diagnosed with colon cancer, you then would have a first-degree relative and you would start at age 35 because that would be 10 years before the colon cancer occurred in that family member. But if you had a parent that was diagnosed with colon cancer at age 70, you would then just start at age 40. Okay, you wouldn't start at 60 or even 45. You would, according to the guidelines, start at age 40 and then do it either every 5 years or every 10 years. That depends on which guideline you're looking at, because some of the guidelines say to do it every 10 years still, and some of them say to do it every 5 years. Personally, if you have a family history, I tell people to do it every 5 years.
Mhm. Oh, let me see here. If cancerous cells are found in the colon, is surgery the first step? Is that recommended?
Okay, so if the cancer is only on the tip of, like, let's say you had a very large polyp, like a 2 centimeter polyp, very large polyp, and there was a little tiny bit of cancer on the tip of the polyp, that's called in situ. And removal of the polyp could be curative and wouldn't require any surgery. However, if the cancer is invading into the stalk of the polyp or into the lymphatics or goes below the polyp into the mucosa of the colon, then surgery would certainly be the next consideration. However, if there's lesions in the liver, lesions that have spread beyond the colon, they may not even do surgery. They may just say you go right for chemotherapy. But if it doesn't show that it's spread anywhere, then yes, surgery would be the next step. And theoretically, in many cases, it could be curative. If it hasn't spread anywhere to the lymph nodes yet, doing the surgery might even cure it and you don't even need chemotherapy. If it's spread to the lymph nodes or anywhere else on the pathology, once the surgery is done, then you might need chemotherapy. Now, catching colon cancer early enough can be very curative. And it does oftentimes respond very well to chemotherapy. So even having a diagnosis of colon cancer doesn't mean there's a death sentence here at all, because there are many, many, many people who survive just fine. In fact, if you looked at the earlier statistics, there was 150,000 people a year diagnosed with colon cancer, only 50,000 deaths a year. So that means only a third of people diagnosed with colon cancer are pretty much dying from it. So 2/3 are still making it through with it. Okay.
Is there an age that you stop doing the colonoscopy?
So yes and no. Right now, the guidelines are to perform screening colonoscopies with no alarm symptoms at all up through age 75 to 80, depending on your health. If you're not a good 75, then we would probably say don't do it at that point. But if you're a really good 80, we're going to say yes, you can do it. And occasionally I've seen people 81, 82, and they're really in good shape. And I think you have to go by what kind of medical condition you're in. And I don't know that I would do somebody over age 82 or 83 per se, but you know, if you're 81, 82 and you're, you know, very athletic, you're out and about, you don't have a lot of health problems, then I think it's still maybe worth doing it at those ages. But the guidelines say to start at age 45 and end between 75 and 80, depending on your health.
There is a note here I'm going to read. It says, my son had high dose radiation in the spine for cancer at age 14. He was having symptoms at age 42 for possible colon cancer. I had to push for a colonoscopy and the doctor did it very reluctantly. He had a precancerous tumor that was removed. Going forward, he'll need one every year. Do you think the radiation caused this?
Radiation to the spine, um, from 20 years ago or plus, 20 plus years ago. Remember that radiation now is much more pinpoint and more focused than it used to be. It's possible that radiation 20, 30 years ago, 40 years ago was a little more broad. But I don't think there's any way you could say that radiation would have caused this. I think that that's really going out on a limb, and that it's very speculative. There's no way you could definitively say anything like that at all. And probably the chances are much, much, much higher that this is unrelated to the radiation than it would be related to it.
Yeah.
The people do get prostate radiation and stuff like that. We generally don't see a lot of increased rectal cancer for people who've had prostate radiation afterwards. So I would say that although you can never say never, the chance is very low.
Now, with that said, having another type of cancer can predispose you for colon cancer?
So there are some related cancers. There are some medical genetic conditions. There's one that's called Lynch syndrome, which is a mutation in DNA repair. And this predisposes people to breast cancer, pancreatic cancer, ovarian cancer, and colon cancer. So if you had 4 or 5 members of your family with breast cancer or pancreatic cancer in the family, then you probably would be at higher risk of colon cancer and would require perhaps earlier screening and more frequent screening. If you had a known genetic condition, then sometimes we recommend colon cancer screening even as often as every 2 years. I don't know about this other person where they said they need it every year. I don't know the particulars on that. I don't know if he had a genetic predisposition or not. But usually, if I diagnose somebody with sporadic non-genetic colon cancer, I tell them to come back at 1 year, then at 3 years, and then every 5 years. That's generally what I tell people to do their screening afterwards. I don't know that, I don't know the particulars in this person's case, but to tell somebody to get a colonoscopy every single year is a lot, unless you know that they have some kind of a genetic condition, or unless they had 30 polyps in their colon or something like that. So I don't know the particulars of that case. I don't know, they said that they had trouble getting it approved. I don't know what the deal is with that, but regardless, that's generally what's done, what I've just mentioned.
Is thyroid cancer related to colon cancer at all?
Not that I'm aware of.
Okay.
There are some very unique genetic syndromes, but I can't think of anything right off the top of the head that links thyroid cancer with colon cancer per se. There's MEN, there's multiple endocrine there's a number of things that might occur in the colon, but they're not necessarily colon cancer. You could get a carcinoid tumor in the colon, which is a neuroendocrine tumor, and that can occur in the location of the intestinal tract, but it's not adenocarcinoma. It's not a common colon cancer. It's a unique form of cancer that's occurring in the colon, but it's not primary colon cancer itself.
And Dr. Tata, you mentioned diverticuli. Do diverticuli put you at a higher risk for colon cancer, or they're completely unrelated?
They're completely unrelated, except that sometimes people get diverticuli because they don't have a lot of fiber in their diet. So it could be an indication of a low fiber diet, in which case that might put you at teeny tiny increased risk because you're not getting a lot of fiber in your diet. But the diverticuli themselves do not put you at any higher risk of colon cancer.
What about hemorrhoids?
No relation to colon cancer, except again, people who have hard stools, maybe don't take enough fiber in their diet, could be more predisposed to getting a hemorrhoid because they could get roughed up if you're straining with your bowel movements.
Okay. Are there any other factors that might qualify you for colon cancer screening before age 45?
Other than family history?
Mhm.
Not for screening, but you may get a colonoscopy because you have something going on. For instance, let's say you're anemic, or you're seeing blood in the stool, or somebody does one of those stool for occult blood tests and it comes back positive. That wouldn't be a screening colonoscopy. Now that would be a diagnostic
Yeah.
colonoscopy because of something going on in the body. Maybe you're having a lot of diarrhea, maybe you're having abdominal pain, but that wouldn't be screening. That would be a diagnostic colonoscopy to look for a source of something else that's going on.
Mhm.
Um, and of course, as I said, if you had a known genetic syndrome, you may start much earlier. If you have a family history, you may start earlier. Um, but that would be high risk screening due to one of those issues.
Okay. Um,
Just so you know, under Obamacare or the ACA, screening colonoscopies are supposed to be without cost as long as you have insurance. That the insurance is supposed to eat the cost of the colonoscopy. If it's a diagnostic colonoscopy,
mm,
such as looking, if you're having rectal bleeding and we're doing it for that reason, then that's not a screening under the ACA. That's a diagnostic procedure. So then it may be subject to any of your insurance issues. I mean, everybody has different insurance, so some
mhm,
people have deductibles, some people don't, that kind of thing.
mhm. And why are people scared of colonoscopy? You hear a lot of people like, oh my God, I had to do this, and they complain a lot about it. Why is that?
Well, I think there's really maybe two reasons. One is it doesn't seem natural to have a tube put up the back way,
Mm,
obviously. But as I said before, you're sleeping for this, and it's pretty anticlimactic. Most people, they're laying there talking, they get the medication, they wake up, and they're like, "That's it? That was the whole thing?" It's like nothing. So, I mean, but look, I mean, mentally, maybe some people are not prepared for that, and I
mhm,
understand that. That's perfectly reasonable. But it isn't such a big deal. The other two reasons are the prep. You have to do this clean out the day before, and people don't like to be on a clear liquid diet for the whole day before, and don't like to take stuff that gives them this cramping and diarrhea. And also busy. Sometimes people are very busy. They don't want to take off time from work. It's the
mhm,
last thing on their mind. They're not thinking about it. They're thinking about other things in their lives, and so it's easy to push it out and not have to deal with it, and sometimes the primary doctors, they're definitely reminding people every time they come in, oh, you haven't done this yet, you haven't done this yet. So I do get people coming into the office saying, my primary doctor's been pestering me for years, and so I'm finally doing it, almost like they've been guilted into doing it or something like that.
mhm,
So I think knowledge is the best weapon here. What I talked about today, make your decisions for yourself. Um, it's not a requirement to get a colonoscopy. It's only a suggestion based on scientific evidence and what's going on out there.
mhm.
And, as I said, if you're one of those 6 out of 100 people, then you'll be thanking yourself that you got it done,
You might have never won any raffles in your life, but you will win this one because that's
Yeah,
usually
well,
how it happens.
yeah. So, so it's a decision you're gonna have to make on your own. But we can only give you the right information and let you make that decision.
Mhm. Are there any complications from the colonoscopy?
There are risks to colonoscopy. There is a small chance if I take out a polyp, you could have some bleeding from the site. Now, this is a bigger risk if you're on blood thinners. Some people are on Eliquis or Xarelto or Coumadin or Plavix or one of these blood thinners. Those patients could be at higher risk of bleeding when you take out a polyp. And if they really need to be on the blood thinner as soon as possible when we're done with the procedure. Let's say they have an artificial heart valve and they need to be on it. Sometimes I'll put little clips at the base of the polyp to help prevent it from bleeding afterwards. But you could be at risk of bleeding for up to 10 to 14 days after the polyp's taken out. Sometimes it can form a little scab and fall off. And occasionally, rarely, I have had to go back in afterwards a week later and put a clip on a bleeding spot to prevent it and stop it from bleeding. But that's the exception, not the rule. I've probably done that maybe 3 or 4 times in the last 10 years. So not that often. Um, it is also possible to tear the colon lining with the scope. That is a risk. We talked about perforation with the CT colonography. When you inflate the colon with air, could something pop? That is a risk, but it's extremely small. The risk of that is one in thousands and thousands and thousands and thousands and thousands of times the procedure's done, somewhere maybe in the ballpark of 1 in 4,000, 4,500 colonoscopies. You have to realize the risk of getting colon cancer is 6%. The risk of having a perforation from a colonoscopy is, 1 in 5,000. So that's a big difference, So the risk of having a complication with the procedure is much, much, much smaller than the risk of not doing the procedure. Okay. And the way I put it is you can walk across the street, get hit by a car. It doesn't prevent you from walking across the street. Okay. But it is theoretically possible that a car could come out of nowhere. You might not have seen it, whatever, something could happen. So, this is just a fact of life that something could happen, but the chances are low. Okay. There are other complications you could get to. You could injure the spleen with the scope, bowing and pressing on the spleen as you're going through there. That's extremely rare. Maybe 1 in 50,000 colonoscopies or something like that. Problems with the anesthesia. I'm not the anesthesiologist, but you could have breathing problems, especially if you have baseline issues with your heart or lungs to begin with. But these are very, very unlikely and rare, but they're not zero.
Okay. What about people with diabetes and the PrEP? It's like basically you're in clear liquid, so you're not eating anything all day, and people with diabetes have to be frequently eating meals throughout the day. So how can they do that?
Well, so first of all, the clear liquids, you can have apple juice or Gatorade with sugar in it. So you're not prohibited from having anything that has sugar in it. And if you choose, for instance, the Miralax prep, where you have to use a lot of Gatorade, you can use the Gatorade Zero so you don't get too much sugar. Then it becomes a question of holding your medications. So if you're on insulin, we usually tell people to take half the dose of insulin the night before or the morning of. So they're not taking the full dose because they're going to be fasting. We try oftentimes to schedule them early in the morning rather than later in the morning, so that they get the procedure done earlier so they can eat again. And certain medications, like Ozempic or Mounjaro or Zepbound or Wegovy, those actually, for anesthesia purposes, should be held for 7 days, meaning no shot in the last 7 days before doing the procedure, because they make your stomach slow down. And the anesthesiologists don't want you to have any food or anything in your stomach for giving the anesthesia. So we do tell those patients to hold their Ozempic, not take the shot for at least 7 days before the procedure. And blood thinners that have to be held, like Eliquis or Xarelto, usually they're 48 hours, unless it's Coumadin, which is longer acting, and that may take 5 days to get out of your system, as well as Plavix, which could be 5 to 7 days to get out of your system.
Well, I think those are all the questions we have, which were a lot. So thank you so much for answering all of them, Dr. Tatar. And also to our attendees, thank you so much for all your questions and comments. And what can I say? I hope that all of you who are listening and you are at the age and even if you're not a high risk, think about preventing colon cancer. And it's really easy, it's a simple test. We have great doctors that, help us be healthy, stay healthy. So please make use of those services. And thank you so much, Dr. Tatar, for being here every year and helping us with this campaign to prevent colon cancer. You're a wealth of knowledge. Thanks a lot.
Not a problem. All the best to you guys.
Okay. Thank you, everyone. And I will see you next week. We are going to be talking about the signs of people with dementia and how we can help them. So more next week. See you then. Thank you.